Welcome to Clinical Guidance for Treating Pregnant and Parenting Women with Opioid Use Disorder and Their Infants, Module 1 of 4. Module 1 discusses pharmacotherapy for pregnant women with opioid use disorder. Other modules address prenatal care and labor and delivery, infant care, and postnatal care, including adjustments to pharmacotherapy for opioid use disorder. The course is based on the SAMHSA publication, Clinical Guidance for Treating Pregnant and Parenting Women with Opioid Use Disorder and Their Infants. The guide is available in print and as a downloadable PDF. Consider downloading the document for your reference as you work through this module, and so you can access the live links to other information. SAMHSA would like to acknowledge the time and commitment of leading experts in the fields of obstetrics, pediatrics, and addiction. Federal representatives from across the Department of Health and Human Services and other parts of the executive branch, and the staff at JBS International for bringing both the guide and this course into existence. At the end of this module, you will be able to select appropriate pharmacotherapy for initiating medication-assisted treatment, also known as MAT, in pregnant women with opioid use disorder, and adjust pharmacotherapy in response to the physiological changes of pregnancy. You will also understand the information that needs to be covered to educate and counsel pregnant patients with OUD about different treatment options and the potential social, medical, and legal consequences of each form of therapy and of opioid use during pregnancy. The opioid epidemic is growing and evolving. Based on figures reported in 2016, an estimated 116 people died daily due to an overdose that included opioids. This number was probably an underestimate. Not all the people who die are necessarily or knowingly misusing an opioid. Not all of them had an opioid use disorder. An opioid use disorder, or OUD, is defined as the problematic use of opioids leading to clinically significant impairment or distress. In 2016, an estimated 2.1 million people had OUD. An additional 2.1 million people misused a prescription opioid for the first time that year. An estimated 42,000 people died from an opioid overdose, with 17,087 of those deaths attributable to prescription drug overdose. The economic consequences of the epidemic are staggering. In 2015, it is estimated to have cost the economy $504 billion. Because you are participating in this course, chances are you are well aware of these national figures. The figures regarding opioid use among women are less well known. In recent years, past month use of heroin or misuse of an opioid analgesic among women of childbearing age has increased with a corresponding increase in infants diagnosed with neonatal abstinence syndrome. Among women who reported past month heroin use in 2016, approximately 2,000 were pregnant. These figures may seem small. It is important to remember that they're based on survey data that exclude institutionalized persons such as jail inmates and people without a telephone. This graph is describing rates of OUD at the time of delivery. It doesn't distinguish between treated or untreated women. To start, please note that the number of women with OUD at delivery has doubled since 1998. The top green line is mothers aged 20 to 34. The line immediately below that, the turquoise one, is all deliveries. You can see by how it mirrors the top line that the bulk of the increase is driven by this younger segment of mothers. This age group went from 1.8 women with OUD per 100,000 deliveries to 4.5 women with OUD per 100,000 deliveries. That's an increase of 162%. There are upticks here in the red and purple lines representing women over 40 and women 35 to 39 respectively. Finally, at the bottom is the blue line for women under 20 with a small but steady increase. Take a moment to watch the video clip and learn directly from patients about their reasons for choosing treatment and the barriers and fears they experienced. Pregnant women who need treatment for OUD have legitimate reasons to feel afraid of the social and legal consequences of the illness and getting help for it. Currently, 22 states and the District of Columbia consider substance use during pregnancy to be child abuse under civil child welfare statutes. It is important for healthcare professionals to know local and state reporting guidelines regarding the use of opioid pharmacotherapy and identification of illicit substance abuse during pregnancy. Women will also be deeply afraid that they've already harmed the baby. The baby is suffering in some way or will suffer in its life due to their OUD. Many women without OUD face similar feelings if they must take medication during pregnancy, struggle to quit smoking, or drank alcohol prior to learning they were pregnant. Nevertheless, pregnancy is a time of hope and potential for positive change for women with OUD, just as is typical for all women. Many of the barriers women with OUD must contend with are exacerbated by living in poverty. Women are at higher risk of developing OUD if they have had adverse childhood experiences, whether physical, sexual, or emotional abuse or neglect. Psychiatric comorbidities contribute to the development and perpetuation of OUD. Usually the OUD will predate the pregnancy, so it may have been going on for a long time, and she may suffer from associated problems such as hepatitis and sexually transmitted infections. She may also have had poor nutrition for an extended time prior to conceiving. Often women with OUD are at the mercy of others for their food, housing, and transportation. They may also come from a family with multi-generational substance use, so the people one might otherwise expect to turn to can't help. This short video will give you perspectives from healthcare professionals and women with OUD. When taken as prescribed, methadone and buprenorphine are safe and effective treatment of options during pregnancy. Being on a medication, even though the fetus continues to be exposed to an opioid, is the safest option because the intrauterine environment is stabilized and stress on the developing fetus is reduced. The expert panel did not discuss or provide recommendations on the use of buprenorphine combined with naloxone, naltrexone, or the implantable forms of buprenorphine because of the lack of published evidence regarding their use in pregnancy. The expert panel advised against medically supervised withdrawal during pregnancy because of the high risk of relapse and associated harms. Thus, in the remainder of this course, the term pharmacotherapy will be used to refer to methadone and buprenorphine. Pharmacotherapy is central to the management of pregnant women with OUD. The goal of pharmacotherapy is to control any withdrawal, reduce cravings, limit other illicit use, and stabilize the intrauterine environment, reducing stress on the infant. Methadone is a full agonist of the mu-opioid receptor. This means there is a linear relationship between the dose and the response. It is extremely well studied in pregnancy and has been the accepted standard of care for pregnant women with OUD since the late 1970s. Methadone is associated with reduced risk of obstetrical and fetal complications, in utero growth restriction, and neonatal morbidity and mortality. In many places, induction into methadone is done in the hospital. This is because methadone must be built up to a therapeutic dose slowly. As a result, the patient may have to endure several days of withdrawal. By keeping her in the hospital, she can receive supportive care and is less likely to use other substances. Depending on her stage of pregnancy, the fetus can also be monitored. Once she's at a therapeutic dose, she will not experience strong effects from another opioid if she uses one, and should not experience withdrawal symptoms. A therapeutic dose of methadone relieves withdrawals for at least 24 hours, reduces or eliminates cravings, and has very high retention in treatment. During the initial period of building up to the therapeutic dose, the risk of overdose if other substances are used is significant. Pregnancy causes important metabolic changes. As a result, during the third trimester, the dose of methadone may need to be increased or divided from once daily to twice daily. However, this is unpredictable, so decisions about increasing or splitting the methadone dose for a pregnant woman can only be made based on patient evaluation. Sometimes methadone levels need to be tested at peak and trough to determine the appropriate strategy. A woman making a decision about pharmacotherapy needs to know the following things about methadone. It can take days to weeks to achieve the optimal therapeutic dose. Even if methadone is started in the hospital, Further dose adjustments may be needed after discharge. Typically, those dose adjustments require daily visits to a federally certified opioid treatment program. Medication for unsupervised administration at home may be offered when specific requirements are met or a medical need arises. Buprenorphine is another pharmacologic option for OUD during pregnancy. Buprenorphine only partially stimulates the mu-opioid receptor. This means there's an upper limit or ceiling to the effects of buprenorphine. As a result, buprenorphine is safer and less associated with overdose. Overdose can occur if it's used with other substances, including alcohol. There are different formulations of buprenorphine. Most of the time, products containing buprenorphine only are used in pregnancy because most published information and the medication labeling supports this. There are providers who will continue a woman on the product containing buprenorphine and naloxone if she was already on it when she became pregnant, or if there's a significant amount of diversion of the buprenorphine-only product in her community. The effect of the naloxone on the pregnancy has not been studied, and the expert panel did not take a position on this practice. The expert panel also did not discuss the injectable or implantable formulations for use in pregnancy, as they were not yet available at the time. As with methadone, buprenorphine has advantages and disadvantages. For example, it has a lower risk of overdose and fewer interactions with other medications. Getting stabilized on a therapeutic dose is quicker and may be accomplished in an outpatient setting, but retention in treatment is lower than with methadone. Buprenorphine during pregnancy results in a shorter course of neonatal abstinence syndrome, but there is little longer-term data on fetal exposure to buprenorphine. It is important for a woman making a decision about pharmacotherapy to know the following things about buprenorphine. It is necessary to exhibit symptoms of withdrawal in order to start the medication. While the amount of clinical withdrawal required to safely start buprenorphine has not been associated with adverse fetal outcomes, it is nevertheless unpleasant. Exhibiting signs of clinical withdrawal is necessary to avoid precipitating acute withdrawal, which can be severe. An increased dose of buprenorphine may be required in the third trimester of pregnancy. Women should also know they will experience clinical withdrawal symptoms when they discontinue buprenorphine, as with methadone. Buprenorphine combined with naloxone is intended to reduce the likelihood of diversion or misuse of buprenorphine. There is insufficient data about the use of the combined buprenorphine-naloxone product in pregnancy to say whether these possible advantages outweigh any risk. Historically, pregnant women who had been on the combination buprenorphine-naloxone product were transitioned to the buprenorphine-only product for the remainder of their pregnancy. Positions in practice are evolving on this subject. A growing body of evidence supports that newborns are not adversely affected by the combination product. Some women who are doing well on the combination product may prefer to avoid any risk of becoming unstable during a switch to the buprenorphine-only product. Any use of the combined buprenorphine-naloxone product during pregnancy must be a shared decision of the pregnant woman and the healthcare professional providing her care, and based on her fully informed consent. Please take a moment to watch these video clips to hear both patient and provider perspectives on pharmacotherapy for OUD during pregnancy. While the expert panel took no position on the use of naltrexone, this important option merits a brief discussion. Naltrexone is an opioid antagonist. This means it binds and blocks the opioid receptor without creating any opioid-like effect. It reduces cravings and has no potential for misuse or abuse. Experts are divided about the use of this drug in pregnancy, and it has not been formally studied in pregnancy. The most likely scenario would be if a woman is stable on naltrexone when she becomes pregnant and wishes to continue because she's afraid of relapsing and does not want to become dependent on an opioid through treatment. The provider and patient must rely on informed consent and shared decision-making in such a situation. The expert panel advised against medically supervised withdrawal from opioids during pregnancy due to the high rate of relapse and associated risks, including overdose and death. Pharmacotherapy with methadone or buprenorphine is the standard of care in pregnancy. However, a woman cannot be compelled to accept pharmacotherapy. If she desires, withdrawal and effort should be made to help her access this care, typically in a residential or inpatient setting. She may opt for pharmacotherapy at some point in the course of the withdrawal. This should be respected and not viewed as a failure. Medically supervised withdrawal from either pharmacotherapy or illicit opioids has high failure rates. A decision to carry out medically supervised withdrawal in pregnancy should be made on a case-by-case basis, and only when the benefits to mother and infant outweigh the risks. Please take a moment to watch the following 2 video clips of patients and healthcare professionals discussing choosing a pharmacotherapy, weighing risks and benefits, and individualizing care. Polysubstance use is common among pregnant women with OUD. The most frequently used substances include alcohol, benzodiazepines, cannabis, and tobacco. While receiving pharmacotherapy, 88 to 95% of women continue to smoke tobacco. Adverse outcomes such as low birth weight and more severe neonatal abstinence syndrome known as NAS symptoms can result from polysubstance use and is strongly associated with tobacco use. Treatment of substance use disorder requires more than pharmacotherapy alone. Behavioral therapies and recovery support are needed to maximize the potential for lasting improvement. Among the interventions that reduce and end other substance use are cognitive behavioral approaches, including motivational interviewing and dialectical behavioral therapy and contingency management. Lastly, a tobacco use cessation program is one of the most important therapies to begin when a pregnant woman enters OUD treatment. These video clips discuss the limitations of pharmacotherapy, benefits of behavioral therapy, and strategies for overcoming challenges and barriers to recovery. Key recommendations of the expert panel on the subject of pharmacotherapy for pregnant women with opioid use disorder are: when taken as prescribed, both methadone and buprenorphine are safe and effective treatment options during pregnancy. The benefits of pharmacotherapy for OUD during pregnancy outweigh the risks of untreated OUD. Medically supervised withdrawal is not recommended for pregnant women with OUD. Increased or split dosing may be required in the 3rd trimester for pregnant women being treated with methadone or buprenorphine. Thank you for taking this course. Please click the button on this slide to complete a brief quiz and claim your CME CE credit.